Thank you, and good afternoon, everyone. Thank you for joining the ongoing discussion on myostatin. I'm Pat Furlong, and joining with us today is Lee Sweeney, who's director of the University of Florida Myology Institute in the Department of Pharmacology and Therapeutics. I know as a community we've been looking at myostatin and imagining it as a potential therapy for Duchenne muscular dystrophy for many years. We've had an experience with the first drug long ago, it seems, with Acceleron's drug, in which the trial was halted due to some bleeding, telangiectasia, nosebleeds, and gum bleeds. And then later, Pfizer initiated a study with an anti-myostatin drug that was recently terminated. So we wanted to come back to this discussion today and talk about what is myostatin, is it a viable option for Duchenne muscular dystrophy, and what might the circumstances be, and how can we better understand progress going forward. So with that, I'm going to turn this discussion over to Dr. Sweeney, and he will begin, and we will facilitate discussion along the way. So, Lee, take it over.
Okay, well, thanks, Pat, and I'm glad everyone could join us today. So, we had a webinar on myostatin a year or two ago, but I think we'll go over some of the basics of it again before we talk specifically about the current trials. As you know, I mean, this slide is not necessary for this audience, but certainly when dystrophin is missing, there's this downstream cascade of effects because of the damage to the cells that ultimately leads to muscle regeneration, which is modulated primarily by IGF-1 and myostatin under normal conditions. Now, without this regeneration, the disease would wipe the muscle out very early on. So it's only the fact that the muscle can repair itself that allows Duchenne to actually proceed as a fairly slow progressing skeletal muscle disease instead of a rapid destruction of the muscle. So anything we can feasibly do to improve the regeneration should slow the disease further. That really is ultimately the idea of why a myostatin therapy might be useful. But as you can see, this is sort of the normal cascade of injury and repair. But normally injury isn't occurring chronically like it is in Duchenne, and so normally you have this nice progression of an early sort of damage followed by degeneration and an inflammatory response, and then the regeneration and the remodeling and rebuilding of the muscle. A big problem in Duchenne is the fact that all of this is going on all of the time, and there's certain signals that are being produced by all of the different cell types involved in the response to the injury and the repair that ultimately confuse them. And so the remodeling eventually stops, and you end up, instead of being able to repair the muscle, you start replacing the muscle with fibrosis and fat. And so that ultimately sums up what happens in Duchenne. It's not that the muscle doesn't have capacity to repair itself, it's just that capacity becomes overwhelmed, and instead of repairing the muscle, you end up with a muscle replacement. And so the disease really is a replacement of muscle with fat and fibrosis. Now, the pathways that control growth can be potentially modulated to make the muscles bigger and stronger. And long ago we showed that increasing IGF-1 signaling would actually produce stronger muscles. And stronger muscles in themselves may not seem that useful in the absence of dystrophy, but in fact, what we were able to show with our IGF-1 experiment is that stronger muscles are actually better in that they lead to the damage being less per unit area of the muscle, and so the disease progresses slowly. So if all you could do is make bigger, stronger muscles, that probably would be useful even in Duchenne because it would slow things down. But what we think myostatin, which is a negative regulator of this growth, what we think inhibition of myostatin might do is more than that, because it has effects potentially on the fibroblasts as well. So we'll come back to this scheme in a moment, but just want to mention that, we're all very much excited about the replacement of the missing dystrophin with potentially microdystrophin in gene therapy. But there are other things that we can use to combat the progression of the disease too. And all of these would be useful to have in conjunction with each other. And number 2 on this list is trying to increase the muscle mass and the regeneration, which is what we think inhibition of myostatin might be able to achieve. So again, going back to these pathways controlling growth and atrophy, this arm that myostatin feeds through, going through this activin 2B receptor, actually signals a cascade that interferes with IGF-1 signaling. So in a sense, IGF-1 and myostatin signaling work against each other. IGF-1 signaling is sort of driving the growth. Myostatin, if you like, is controlling the gain on that growth. If you got rid of myostatin, then for a given amount of IGF-1, you would have much more growth. And that's what we think happens by inhibiting myostatin. Notice at the same time, there are other factors other than myostatin that signal through the same receptor. Activin A, GDF11 also signal through the same receptor. And so there are other things circulating besides myostatin that can inhibit the growth that's being driven by IGF-1. Now, ultimately, that means that they all signal through these activin receptors, and one would like to inhibit signaling through this receptor. The majority of the signaling is coming from myostatin itself. Activin A and GDF11 contribute to some extent. And so depending on how you go after the inhibition, you might be able to inhibit all of these or just the myostatin itself. I will say that most of the antibodies that recognize myostatin also recognize GDF11, and so most of the strategies at least inhibit these two, and there are other strategies that also inhibit activin signaling. So we haven't really told you what myostatin is. I mean, it is a protein. It's related to the TGF-beta family of proteins. And its main function in the body, we think, is to try to is a negative regulator of growth, both in skeletal muscle and in the heart, to try to keep the muscles from getting too large when there's excessive drive for hypertrophy in the muscles. So this is thought to be important in skeletal muscle because if the muscles get too large for the amount of nuclei that are in them or just too large in general, then it's difficult for the fibers to function properly. So you don't want the fibers just to keep getting bigger and bigger and bigger. But nonetheless, it could be in pathological situations, such as Duchenne muscular dystrophy, that blocking the myostatin could increase growth and strength in the muscles, as well as I mentioned that we think because of other effects that myostatin has, it could also improve the regeneration itself, which obviously would slow the progression of the disease. So in animal models, myostatin inhibition has been effective, and especially in the dog model, the golden retriever model of Duchenne muscular dystrophy, which is probably more relevant than the mouse model as far as predicting what might happen in humans. There was significant hypertrophy of the muscles. So it differed from muscle to muscle, but on average it was maybe between 15 and 25%. There was also a decrease in fibrosis, and this may be due to something that Catherine Wagner showed some years ago, that myostatin receptors are also present on the fibroblasts themselves, and in fact, by inhibiting myostatin, you lessen the drive on the fibroblast, which would also potentially lower the levels of TGF-beta that are being made in the muscle, and decrease the fibrosis by a direct effect not on the muscle but on the fibroblasts. This in turn could be a means of allowing more successful regeneration because, if you like, there's sort of a competition between the fibroblasts driving fibrosis and the muscle cells making more muscle, and TGF-beta that is being made by the fibroblasts actually do inhibit that. Is the audio all right?
Yes, I think so, Lee.
Okay.
Yeah, Lee, you sound fine.
Okay. At any rate, so the human trials then going after myostatin inhibitors that have different actions, but all with the same goal. And I did mention that the heart also uses myostatin inhibition as well as GDF11 uses myostatin and GDF11 to inhibit runaway hypertrophy in the heart. And so there is a concern that in older patients, once they have cardiac problems, that inhibiting myostatin and GDF11 could be a problem from the cardiomyopathy standpoint, but that's never been really seen in either any of the animal models, but it's hypothetically an issue to think about. So the bottom line is inhibiting myostatin looks a lot like increasing IGF-1 because of the competition between the two. And in the animal models, you see improved regeneration, you see muscle hypertrophy, and less fibrosis. Again, because of the signaling through this receptor is not just confined to myostatin, one can try different strategies to go after either myostatin alone, myostatin and GDF11, or take out activin A as well. And it's been shown in animal models that if you block all of them, you get more hypertrophy than if you just block one of them. So the approaches that have moved forward, just review. You remember Myo29 was the first attempt by Wyeth to target this pathway. And it failed largely because the antibody itself failed to really neutralize myostatin to the extent that we think is necessary to achieve the effects. So because of that, they began working on a new generation antibody that was then developed further by Pfizer and is the one that was in trial, and now the trial has been halted because of the lack of hitting their primary endpoint. Roche has initiated a trial with another anti-myostatin agent, in this case an adnectin other than the antibody, but the idea is much the same. There are other ways you could inhibit it, including soluble activin 2B receptors, and you may remember that the first attempt at that was with a soluble receptor that inhibited perhaps too many things, as I'll show you on the next slide. And because of that, the trial was halted due to bleeding, but the bleeding isn't really an effect of inhibiting myostatin. If you just take the wild-type receptor and use it as a trap, you pick up all sorts of signaling molecules besides just myostatin and GDF11. You pick up a number of BMPs as well, and it's thought that BMP 9 and 10 were probably the ones that were responsible for the bleeding. By inhibiting those, you cause problems with the vasculature that led to the bleeding. So by eliminating these two molecules as targeting, one could, basically recast the receptor as has been done to go after the activins as well as myostatin and GDF11. And you will note that this receptor does not bind TGF-beta, which is shifted all the way over here. So, in summary, the animal models are really the major support we have for this pathway being potentially useful, both in juvenile and adult mice as well as in dog models of DMD. We've seen efficacy both in terms of increased strength of the muscles and better regeneration and less fibrosis in the muscles. I'll also say that, from the standpoint of the animal studies, it's also shown that if you inhibit activin A as well, you can get a greater sort of muscle hypertrophy. But if you go inhibit other members such as GDF9 and 11, then one can actually get potential side effects, not because of their effects on muscle, but because of their effects on other tissues. And so one probably does want to restrict the inhibition to the molecules that have a direct impact on muscle. There's still long-term questions about the heart, but they have not been a problem in any of the animal models to date. Okay, so here is a table summarizing the state of development of myostatin inhibitors. It's been looked at beyond Duchenne muscular dystrophy. Novartis has had it in trials for IBM. It's being looked at and for sarcopenia by Regeneron as well as Novartis. So there's a lot of potential impact of myostatin inhibition in a number of human conditions besides just Duchenne, as well as other types of muscular dystrophies, FSHD, limb-girdle muscular dystrophies, for example. And as you see, there are different ways of inhibiting, as I've already mentioned, just going specifically after myostatin and GDF11, or going after things more broadly, such as using a follistatin ligand trap, which picks up other ligands besides these that could lead to further improvements in the muscle. Follistatin is a natural sort of binder of myostatin and related proteins that can be used to sop them up and prevent their impacting the muscle. So we mentioned that Acceleron's early attempt that failed because of bleeding, and so they have gone back to the drawing board and done a couple of things. One is this modified follistatin, which can go after myostatin, which is also known as GDF8, as well as some of the other negative regulators of muscle that we talked about, as well as a redesigned receptor, which can avoid some of the earlier toxicities, the bleeding, because it's now been modified to be more specific for the signaling molecules that affect muscle. So Pfizer terminated their trial, and at this point, basically what we know is that they terminated it because they failed to hit the primary endpoint, which was the four-stair climb. So we don't have enough data to know if it failed to meet the primary endpoint because it failed to have any impact on the muscle, or just not sufficient impact to change their primary outcome. So in that sense, we can't really speculate in any detail what happened. It is disappointing, obviously, that they didn't affect the four-stair climb, because many of us anticipated that there would be enough increase in the muscle strength potentially to impact the four-stair climb in a meaningful way. But I think it's too early to write off this mechanism until we better understand why their trial failed. This is a little more detail about what that study was. It was a double-blind, placebo-controlled, multi-center trial. The boys were between the ages of 6 and 15. It was mutation blind because, importantly, unlike some of the therapies that we've talked about in the past, this one should affect anyone with Duchenne, no matter what the mutation is that's leading to Duchenne. So this was a 2-year study within an open-label extension, and basically, as I said, the primary outcome measure was to be the four-stair climb. So obviously, we don't know enough to know whether this didn't work because it was the wrong endpoint, and therefore the trial design was the problem, whether it was the right dose, whether there was enough target engagement, enough inhibition of myostatin to have the desired effect, the right patients, there is Duchenne patients in general have less myostatin than do unaffected individuals. That's also true in the animal models, however, and even though the levels are lower, the animal models clearly show that further lowering of myostatin signaling does have an impact, even in the presence of lower than normal myostatin. And whether or not the trial was long enough to see the change is always a question, and a question that we're faced with more and more, given especially such as the exon skipping taking so long to see the clear divergence of the populations. So we have lots of questions, and we're not really going to be able to even start speculating as to what was the problem with the trial until we see all of the data from the trial, which I gather is going to be a few months away at this point. In the meantime, a different anti-myostatin inhibitor, the Roche Genentech anti-myostatin adnectin, is moving forward. And so let's talk a little bit about that trial. This began with Bristol Myers Squibb when they did some of the earliest work in humans with this adnectin, and then they've licensed it to Roche, and Roche is now moving forward with it and has a phase 2/3 study underway in Duchenne, in ambulatory Duchenne patients. So, again, even though it's a slightly different type of molecule than an antibody, the idea is the same. It's to try to neutralize myostatin. And as I mentioned, it's probably neutralizing both myostatin and the closely related GDF11 because it's very hard to distinguish the two. It's administered once weekly by sub-Q injection. An injection under the skin, and they're doing that in the abdomen. And it's broken into these phases. So the first phase was in healthy volunteers, just to establish safety. Now the second phase, which has completed recruitment, is looking at 43 ambulatory boys with Duchenne. So again, it's mostly for safety and tolerability, but obviously we're going to have some preliminary read on some of the functional outcomes in this study. And then the study that is to really look at efficacy in some detail is the study that's now recruiting, the so-called Spitfire study, and therefore we have no data to look at from the Roche trial. But again, the idea is similar to what Pfizer was attempting, and although it's a different drug and therefore may have both a different efficacy and safety profile. So the current status of the early safety study in Duchenne was that 43 boys were enrolled. They've are all now receiving the drug on an open label basis, and there was some data already presented, which I haven't actually seen, but maybe Pat or someone who has seen it can comment on the early data, but there was early data presented earlier this year. So Pat, would you like to comment on what was disclosed at that meeting?
I think basically what the fundamental disclosure was is that the drug was proven safe, at least the safety study, and that they had found a dose that they felt like they were going forward. To my knowledge, there was no efficacy presented during that study in that conference.
Okay, yeah, it was probably too short a period to expect to see much of an efficacy readout, but certainly long enough that they would have uncovered any safety problems if they existed.
Exactly. Mm-hmm.
So the study that's enrolling now will be able to look at the potential efficacy, and that's going to be in 159 boys, and with a 2-to-1 randomization, so twice as many boys will get drug as get placebo. so there's not too much to say about that at this point, other than it'll be blinded over 1 year, and then at the end of that year, the boys will all be given drug while the data from the trial is being analyzed. And obviously, if the trial is successful, those boys will be given the opportunity to stay on drug. So the primary objective of the trial is to, again, look at the four-stair climb as the functional outcome to see if by inhibiting myostatin, one can improve their ability to perform. There are also secondary readouts that are going to be looked at. The North Star composite, which contains the stand to supine and the 10-meter walk run, as well as other pediatric outcomes, and as well as just strength testing and 6-minute walk distance. In the age group that's being investigated, we think many of the components of the North Star are going to be the most reflective. Obviously, the four-stair climb was chosen as the primary. It's not within the North Star functional evaluation group, but it's something that the FDA views as very, very much life-changing in these boys. If they can't ascend stairs, then obviously it's a major life-changing event for them when they lose that ability. So the ability to maintain it would make the drug have quite an impact from a functional standpoint. So the inclusion, again, this is mutation agnostic. It doesn't matter how you get Duchenne. If you have Duchenne, then you would be eligible. But the diagnosis has to be confirmed by both medical history and genotyping. So these boys need to be ambulatory without assistance. Obviously, since stair climbing is the primary outcome, they've got to be able to do a four-stair climb ascent in less than 8 seconds at the beginning of the trial to make sure that they're functional enough that the drug could have an impact. Corticosteroid use is being required. This is something that's going to be interesting down the road, because what I didn't mention is that none of the animal studies were ever performed with the use of corticosteroids, and so we don't have animal data that really looks at the interaction. But since it's the standard of care in Duchenne, it was decided that corticosteroid use should be mandatory, and then the myostatin inhibition is going to have to show benefit on top of the corticosteroid use. So the key exclusion is basically that the boys are going to have to be able to do the procedures, the outcome measures, the testing, and also they can't have been taking medications like growth hormone or any sort of anabolic steroids or androgens that would then confound the results of the trial. So that's really where we are. I mean, unfortunately, the Pfizer trial was a big disappointment in that they didn't meet the primary outcome. There was no difference. Whether or not this is because the target engagement wasn't reached, whether or not just in this group of boys inhibiting myostatin further, since it's low in the first place, is having no impact, or whether it's some other factor, we don't know, because we don't know if there was any discernible hypertrophy in the muscle. I mean, it's possible that the muscles are bigger, but just not functionally better. So we're left with more questions than answers. But the animal data still points to this being a potentially useful way to proceed to try to slow the progression of the disease. And whether the effect is smaller than what we saw in the animals, and therefore it'll take more time to see the impact than 1 year, is still another question. And I think we can be able to have a more informed discussion in a few months when we see all of the data from the Pfizer trial, and that may give us some more insights as to whether the effect is just smaller than we were expecting or whether they just failed to see any effect at all. So Pat, I'm sure that you and others have other questions around this, so I'm going to give it back to you at the moment.
Okay, thank you, Lee, and thanks very much for that, for really going through the slides in such a detailed way. So I wanted to go back to slide 15 and just make a point about, I don't know if we can get back to slide 15. And this was really about reformulation, and I think the point there is really about the fact that sometimes you reformulate a drug and make it a bit different, and then you see less side effects or greater impact. And I think that's in that Acceleron study where we first saw those nosebleeds and that study was terminated, then the reformulation is getting around exactly that because they learned something about side effects. Can you just speak to a little bit of reformulation, how they sort of redo things so that the targets are a bit different?
Yeah, well, I mean, they've taken two different strategies. One is to use follistatin, which doesn't, or at least a modified follistatin, which doesn't inhibit the molecules that were responsible for the bleeding, and so it's focused much more just to go after the molecules that would give the muscle growth effect that we want and not have effect on other tissues, such as on the vasculature that cause the bleeding. And the same idea with their modified receptor ligand trap. By modifying it, you can also make it not bind the molecules that were giving the side effects, the unwanted side effects, and still maintain the ability to inhibit the compounds that were giving muscle growth. So they've redesigned the reagents to get around the side effects that we saw before and still try to have a big impact on the muscle hypertrophy.
Good. Thank you. And go to slide 16, if you don't mind. So this is just sort of a description of how they changed, and so I thought it really would be good to point that off or point that out to the group watching. Also on I think it's slide 17 with the Pfizer. This is directly from Pfizer's press release. So I think we really have to make the point that Pfizer terminated the study based on the fact that it didn't reach the primary endpoint. I am convinced that Pfizer is going to do analysis and further analysis to better understand if there was a group that responded to this study and really think through, was this design, was this the drug, was this the dose, was this the appropriate time frame for them to see change. So I think the nuance of the definition, they terminated the study. They didn't say they were closing the door on their particular drug. So I wanted to make sure that was known. And then if we go back to slide 27, and then I'll take some more questions. Are we at 27? Okay. Roche did present the safety data, but I think it's really important to understand is that they are looking at that at the North Star, also in the steroid use, because this is a global trial, so it's in places U.S. and ex-U.S. 159 boys, and while steroids are the standard of care, as we all know in our experience, there are very different ways of giving steroids, very different regimens recommended by different physicians. So some physicians in Europe are using 10 days on and 10 days off. There are other physicians in the U.S. and ex-U.S. that are using a high-dose weekend dose of steroids, which is 10 milligrams per kilogram divided over 2 days. And then there's a daily dose of prednisone and or deflazacort that is being used worldwide. So I think as this study goes forward, they will be able to really take a look down deep and decide if the corticosteroids have an effect, or those who, in the event that Lee talked about the mouse models that were not done with myostatin in the context of steroid. So we'll be able to understand that a bit better as well. And as we hope and dream about combination therapies, we'll get to the right combination. So, Lee, some of the questions that have come in were really about Becker, and do you feel that this approach of anti-myostatin would help Becker patients?
Yeah, I think Jerry Mendel's gene therapy trial sort of illustrates the potential because, Jerry's follistatin gene therapy trial basically was using follistatin to block myostatin signaling. Now, in the case of follistatin, it would take out myostatin as well as GDF11 as well as activin A. So it probably has a slightly bigger effect than just blocking myostatin and GDF11 alone. But nonetheless, it does speak to the fact that it should be efficacious in the Becker patients. And so certainly it would be worth looking at in Becker as well as in Duchenne. And again, the Becker patients generally aren't on corticosteroids, so it would be interesting to see in a population that has a slower progressing disease than in the case of Duchenne and not having corticosteroid use, what impact the myostatin would have.
Yeah, thank you. And do you can you tell us a little bit more about Jerry's follistatin study and where that's going or has gone?
Well, I mean, the results. So what Jerry was doing was injecting an AAV that expressed follistatin, but he was injecting it just into the thigh. So the impact was on just the thigh muscles, and this was based on some earlier animal studies that he had done. And he was showing increased muscle size and strength and improvements in 6-minute walk in these ambulatory Becker patients. It was a small group and obviously not a blinded placebo-controlled trial, but it did look very promising. And I'm not actually sure what Jerry's plans are. You may know better than me as far as where he plans to take this at this point. But it certainly looked like it did provide benefit, and so I think even if the gene therapy approach wasn't moving forward, it would be interesting to see what an anti-myostatin therapy of a different sort would do in that population.
Yeah, thank you. I don't think at the moment he has any plans to continue the follistatin study in Becker or IBM as it was done, but certainly they're doing considerable gene therapy studies up at Nationwide and other places, so perhaps it'll come back on the radar. One of the questions that has come in is, does the anti-myostatin have any impact on satellite cells? Well,
the literature is a little complicated in that. Some of the literature says it doesn't directly have any impact on the satellite cells, but as I was mentioning, it could indirectly have an impact if in fact it's inhibiting the fibroblasts, which are primarily churning out TGF-beta, which in turn inhibits the satellite cells. So in the end, it may allow the satellite cells to proliferate better, not because of a direct effect on the satellite cells, but because it has an effect on the fibroblasts, which are in turn inhibiting the proliferation of the satellite cells.
Okay, thank you. A couple other questions have come in as well. One of the issues around the study of the Roche Genentech study is that they are moving toward the North Star as part of the inclusion criteria. The North Star is a global measure looking at a variety of functions, as we know, and it's a measure that the FDA and I think the EMA both have really come to appreciate because it is a much simpler sort of approach in terms of these 17 measures. The individual can do it, does it with help, or can't do it at all. So it seems to be a very acceptable measure that people are using and seem to be very happy with. Trying to go back to a few questions here that we.
Yeah, well, I mean, I think the positive thing about the North Star is that it allows you to capture improvements at various stages of the disease because, the boys will have lost the ability to do certain North Star functions at given points in their disease progression. And in the age range that's enrolled in these trials, they probably are starting at rather different North Star scores. And so you can look to see if you're improving the North Star score, period, not based on an absolute North Star score, but based on improvement from where the boys started.
Right. And I can say we just had a message from Roche. We are able to say out loud that they have submitted an amendment to switch from the forced air climb to the North Star as the primary. And this happens in studies as they go along, that the sponsor submits amendments to the protocol that change some things within that protocol, whether it's expanding the number of patients or maybe expanding the age, or in this case, Roche is really changing from the primary outcome measure. The amendment is suggesting to change from the primary outcome measure, the forced air climb, and really have the North Star as the primary. So they will let us know once that amendment is accepted by the FDA. They also mentioned that in addition to their presentation, they did, where we talked about safety, they didn't have efficacy in terms of outcome measure, but they did show robust myostatin suppression, about roughly 3 to 5% of muscle size increased as assessed by DEX and MRI. So that was publicly shared at the meeting as well, and so thank you for that. One of the other questions is, what's the target myostatin inhibition for these studies? And as mentioned in the Roche study, 3 to 5%. But do they plan to remove, and this is for you, Lee, would you remove all the myostatin in the body? What would that?
The animal studies that have been done have really attempted to block as much as possible. And as I said, I think from the standpoint of seeing as much impact on the skeletal muscle as you can, then you would want to try to neutralize all of the myostatin. So that we think that's the goal, and it's when we say neutralize all the myostatin, what we're talking about is mostly you're judging from the circulating myostatin, and from whether or not that means it's all neutralized at the tissue level is unclear. And in fact, it'll be interesting to see from biopsies in the boys what level of inhibition has been achieved at the actual tissue level as opposed to in the blood. But I think the goal is to try to inhibit it as fully as possible.
Yeah. And one question that's come in, I haven't heard about Givinostat mentioned. Is that the same idea?
Well, not really. I mean, Givinostat has a variety of effects, and one of the ones that was described was increasing the levels of follistatin, which then would then play into this, because then it would lead to inhibition of myostatin. But Givinostat does a lot of other things too, so you can't really look at it as purely an anti-myostatin therapy, because it's a multifunctional, multinodal therapy. That maybe one component of it might be some inhibition of myostatin, but by no means should you view that as an anti-myostatin therapy.
Right, because it's anti-inflammatory and suggested to be anti-inflammatory and antifibrotic as well. Isn't that correct? Yeah,
and it may also have a direct impact on regeneration. So it's doing a lot of things potentially, and so it would be wrong to sort of lump it in as just another anti-myostatin approach.
Right, so that's a far different approach. Yeah, I just wanted to make that clear. I think, Lee, you've answered all of our questions thus far, and I know this conversation will be ongoing, and we'll, at some point in the future, hopefully have another webinar describing some of the results or some of the learnings from the Pfizer study and next steps, and certainly as we learn more from the Roche study and other studies that are happening in other muscular dystrophies and other diseases. So the more we learn about the anti-myostatin or inhibiting myostatin and building muscle, the better as we make these decisions and hopefully see a therapy at some point. So, Lee, thank you very much for joining us, and thank you all for joining us. I hope you've learned something. This will be posted and available online in the next day or so, and we thank you for joining us and hope you'll join us for the next webinar. Thank you.
Okay, thank you, Pat.
Thanks, Lee.